Thanks, everybody, for coming. With me are Senator Isakson, Congressman Paulsen, and Congressman Welch. And we're each going to make a short statement. Shouldn't take but 90 minutes or so. It won't be long, but no, we're going to be brief. The Medicare program that millions of Americans treasure is now dominated by cancer and diabetes and heart disease and other chronic conditions. And we believe it's time for reform that offers seniors with these health care challenges better quality, more affordable care. Fortunately, we've got with us this morning several pioneering healthcare leaders that are paving the way for reform now. And the bipartisan legislation that we propose today is designed to remove the government shackles on innovation so that these leaders can become the norm rather than the exception. Now, we'd like to start with a little bit of good news. When the Senate Finance Committee, on which Senator Isakson and I serve, recently approved legislation to fix Medicare's broken system of reimbursing doctors, our bill locked in specific incentives to move away from fee-for-service medicine. To that finance bill, we were able to add the foundation for improving chronic care for seniors, reforms that guarantee many more seniors access to individual care plans that are tailored to their unique needs. So the four of us are here this morning to build on that progress and introduce a bold, fresh approach in Medicare. The idea that chronic care ought to come first. And our bill does that by the following. First, we create better care health practices and plans that empower teams led by nurses, doctors, and physician assistants that adhere to the highest quality standards. These innovators would receive one payment for their collective efforts to meet the chronic health needs of the seniors who are enrolled. This means we're going to give providers the flexibility to deliver the right care at the right time, and that is not done today. Second, because most seniors don't have access to coordinated chronic care, we set aside federal rules. I won't go into all the root canal-like discussion of what those are. There's something called the Attribution Rule. And in effect, these rules prevent the teams from actively reaching out to the seniors who would benefit most from the kind of specialized chronic care we advocate. Third, our legislation also changes federal law so that participating practices and plans can reward seniors who participate, and this means they would get lower out-of-pocket costs when they work with their health care team. The chronic care bill recognizes also that seniors live all over the country, and a big part of our work is to make sure we bring providers and plans to every nook and cranny of the United States. And for those seniors and providers in rural or underserved areas, the legislation uses telemedicine in some fresh ways to connect seniors, families, and communities who want to monitor and help older people manage their chronic conditions. A word about the private sector. We want to thank all our partners because we know you're making progress. The reason for our legislation is there shouldn't be as many barriers when seniors and providers arrive at the gates of Medicare. Let me wrap up by saying that we're especially proud in Portland, my hometown. I desperately wanted to play for the Portland Trail Blazers, which was a delusional theory because I was too small and I made up for it by being slow. And we're very proud at plans like Kaiser and Providence and others that we have in our community that bring this coordinated care, better care at lower cost. And in Oregon, we want to make sure that all the rest of our state and the rest of the country can have access to that kind of care. I'll close with just two last points. This is really, in our view, what we need to do to change the debate here in Washington, D.C. about Medicare, which, as you know, has not exactly been the ideal drill in bipartisanship in the past. Every day, Americans hear statistics about the impact chronic illness has on families, on productivity, and the economy. But I can tell you, I have not been to a press conference, certainly not one like this, that involves providers and practices and seniors and others, where everybody in the room, Democrats and Republicans, wants to talk about solutions to a big issue that protects Medicare's guarantee, which is what it is for seniors, and does it in a way that's going to contain costs. And the last point is just going to be personal. These are the issues that drove me into public life. 40 years ago, when I had a full head of hair and rugged good looks, I was a staffer to our Senator Wayne Morris. And seniors would come up to him and say, Wayne, what happens when my benefits get cut off, or I'm caught up in the bureaucracy? And he'd say, Ron here is going to look it up for you. And I'd go, me? What do we have then? And back then, we didn't have the network of services that we had. I called up every attorney in town, asked them to volunteer their time helping low-income seniors at senior centers. We organized the Oregon Gray Panthers. And so this is my passion. This is why I went into public life. And I just feel shot in the arm with good luck to have these wonderful partners. And we're going to hear from Senator Isakson, then from Congressman Paulsen, then from Congressman Welch. We'll have softball questions. Our providers are going to be available to take it. If you want to ask anything of us, give my friends here the difficult ones, give me the softballs. But let's all welcome Senator Johnny Isakson.
Thank you. Well, thank you all for being here. Particularly, I think our providers, thank you very much for coming today to tell the real life stories that you realize in your practices. Ron ended his remarks with a personal note. I'll start mine with a personal note. My brother and sister and I cared for my parents in their Medicare years who had complicated chronic diseases. I understand firsthand the problems that brings about and the tremendous need for us to improve innovation in providing better quality at lower cost, which is doable and being demonstrated around the country. You know, the pathway to solution to major problems is paved with the bricks of innovation and incentive. This bill is about incentives for people to innovate a better quality of care at a lower cost to the country. That is a winning combination and it's something I am proud to be for. As a Republican, I always try and work to have efficiency and savings in government. But I also want government to deliver on the promise it's made to the American people and the promise they've paid for. Every American today that's been working since 1968 has paid 1.35% of their income, their total income, into Medicare. They deserve a quality return on that investment. And coordinated care of chronic disease is one way to bring about a quality of care at a lower cost to the American people. So I am honored to join with our House members, with Senator Wyden, and I think with a large chorus of members of the House and Senate who will recognize this is a pathway to innovation and it's incentivized by the Medicare system, and that's a winning combination. I'm proud to be a part of it, and I hope you'll join us in the support for this program as it moves to the Senate and the House. Thank you, Ron.
Well said. Congressman Paulsen.
Well, good morning. I'm Erik Paulsen from Minnesota's 3rd District, and I want to thank Senator Wyden, Senator Isakson, and of course Congressman Welch for their leadership and working together on a big issue, and thank all of the other groups and leaders who are here as well, in particular folks like the Mayo Clinic, Minnesota's Mayo Clinic, who have lent their support and their knowledge to help move this issue and this legislation forward. Too often, I think, as Senator Wyden said, the debate in Washington is, when it's centered around Medicare, we're given a false choice, either to slash benefits or to cut payments to doctors. There is a better way. And our legislation is an important bipartisan step forward to helping put Medicare on a path towards long-term solvency. It demonstrates that it is possible to find common ground on a bipartisan basis to find some real solutions to some big challenges. And as a first step to extending the life of Medicare, both the members of the House and the Senate have taken bipartisan action to advance a permanent fix to the formula how we pay our doctors under Medicare. And it provides stability, it rewards quality, and it gives efficiency for both doctors and patients. And what we're promoting today and offering today is that next step. What will absolutely help bend the cost curve and improve chronic care management. And here's who we're trying to help. It's a senior who lives in my district named Darlene Park, and she's a senior who lives in my district. She suffers from multiple chronic conditions. She suffers from arthritis. She suffers from diabetes. She takes a variety of medications every day. The complexity involved with gaining input from her many doctors and nurses makes it very difficult to manage her own health. And this is a difficulty that many seniors are facing in Medicare today. And focusing reform on chronic care management and coordinated care will not only improve the overall health care delivery for seniors like Darlene, it will absolutely lower costs and help ensure the long-term solvency of Medicare as well. And I think that by taking advantage of technology and innovation such as telehealth, we can break down the barriers, the geographic barriers that currently do plague the system. And that's going to allow us to bring forward chronic care management skills and experience for providers like Minnesota's Mayo Clinic to the most rural and underserved areas of the country. So this bill is going to give health providers and plans flexibility to incentivize wellness and prevention. And with nearly 10,000 people retiring each and every day, this is an important step forward so that providers have the ability to work with new Medicare patients to take control of their chronic conditions early on. So we can create a better system, and I'm excited to work with some great partners on a bipartisan basis.
Well said. Good.
Thank you. Senator Wyden, you had the delusion you'd play for the Trailblazers. I was convinced I was going to be the next point guard for the Boston Celtics. But you know what's not a delusion? This healthcare progress that we're here on a bipartisan basis to promote. You know, Eric just gave the example of Darlene, his constituent, but Darlene is the majority of folks on Medicare. 63% or 68% of all the Medicare folks getting health care have a combination of chronic diseases. And 93% of our Medicare spending goes to the treatment for those chronic care diseases. And we're just stuck in this fee-for-service system that really constrains the ability of our providers, our hospital administrators, even our insurers, from rationalizing that care that gets coordinated so that the senior is not treated like the ball in a pinball machine, just bouncing from one procedure to another with really no one overall in charge of how it works. And what all of us have seen is that the person who right now under the current system ends up coordinating the care, if that senior has somebody, is lucky to have somebody, is a family member. It's a spouse, it's a son, or it's a daughter. So the issue here is how do we give folks better care? And the irony is that the answer is through lower cost. But lower cost means that we've got to change the fee system that really constrains the ability of our providers, our doctors, to deliver the care that they want. So this legislation, bipartisan legislation, is focusing on value and not volume. And that is the right approach, we know, for treating seniors with these chronic illnesses. And our proposal, by the way, builds on groundbreaking reforms that focused on coordinated outcome-driven care in the Vermont Blueprint for Health. And when we passed that legislation, a lot of our providers are doing this this coordinated care. It was bipartisan then. We had a Republican governor, Jim Douglas, and a Democratic legislature, and we figured out if we can find a way to let our doctors and our hospitals deliver care in the way that works for seniors, lower cost, but have a steady income stream so that they know they can meet the bottom line. That's going to be good for the quality of health care. It's going to be good for the long-term fiscal sustainability of Medicare. And it's going to give us that opportunity to deliver on the promise that all of us aspire to, and that is care for everybody when they need it and where they need it. So I am really quite happy to be here with my colleagues and appreciate the leadership that Senator Wyden and Isakson have offered. But I also really appreciate the providers who need a partner here in Washington who make it possible for you to do the hard work on the front lines that's so essential to the well-being of our seniors. Thank you.
Well said. Let's do this, let's get our partners up here to join us as they come. I'll just give a quick introduction. Dr. William Bornstein, Chief Quality and Medical Officer of Emory Healthcare in Georgia. David Sertner is here, Legislative Counsel with AARP. Dr. Ken Coburn, CEO and Medical Director of Health Quality Partners in Doylestown, Pennsylvania. Mr. Andrew Dreyfus, President of Blue Cross Blue Shield of Massachusetts. Mr. Herb Fitch, President of Cigna of Nashville. Dr. Alan Muni, Chief Medical Officer with Cigna Spring in Nashville. And Dr. Andrew Rusine with Montefiore in New York. Ground rule is softball questions for me from the press, difficult ones for my friends, but let's just throw it open to the press for a few minutes. And also, we're going to try and stick around. I think certainly a number of us can afterwards to visit with people as well. Yes?
In the past, you've introduced the Health Advances Act, negotiating drug prices and introducing medication.
You're going to go into my whole shady past?
Are those ideas, are you still interested in those ideas, or does this replace those ideas?
What we tried to do, particularly after that divisive period in 2012, we had another presidential campaign where the discussion of Medicare was not exactly for the faint-hearted. What we said is, we're going to try to see if we can come up with a fresh strategy to deal with what we all identified as the major challenge. This is where most of the Medicare money goes. Folks, Medicare in 2014 is real different than Medicare when it began in 1965. For example, diabetes, there is a much higher prevalence of diabetes in 2014 than there was in 1965. So if you're serious about protecting the guarantee for seniors and finding ways to hold down costs, it's not unlike what the fellow said about why he robbed banks. This is where the money is. This is where a treasured program for millions of seniors, Medicare, is today. These are the big challenges, and I'm going to let any of my colleagues chime in, but this, to us, is where you have to go if you're serious about Medicare reform. This is where the seniors are. Any colleagues want to add to that? All right. Any others? Yeah.
Is this intended to replace the ACO model, or is it going to build off of the ACO model in some sort of way?
It builds off it. I mean, clearly, members of Congress are going to have differing views about ACOs and their present structure, but what we all agree on, the four of us, and we're starting to make some headway on this with the changes in the Medicare reimbursement system, is we've got to move away from volume-driven fee-for-service medicine. This is important in rural parts of our state. Congressman Welch's state has done some creative work in Vermont on this. And my state has both worlds. In Portland, we're really the leaders in terms of coordinated care. In parts of the rural areas, we have problems getting any practitioners at all. So this builds on the effort to try to integrate care. Yeah.
Senator, are you essentially previewing, if you will, your first bill or your first legislative effort when you take over the Finance Committee?
The Finance Committee has one chair at a time. And we, the four of us, have been working on this bill for a long, long time. And I'll let my colleagues, I really would like to get their views on this. We've watched what's going on in the Congress right now. This week, there's been a sense on the 3-month jobless bill. People have wondered, can the Senate order a Coca-Cola, let alone, deal with a major issue? The four of us are trying to say, this is what we see in our communities day in and day out. This is arguably the premier domestic issue of our time. And those big issues require a bipartisan approach. So let me bring in, my colleagues, on this, but that's why we're focused.
Please don't be confused. We have been working on this for a long time. The coincidence of Max Baucus becoming the ambassador to China and Ron Wyden ascending to the chairmanship of the committee is irrelevant compared to what we've done on this bill. It's fortunate, but it's irrelevant. And I think that's the best way to put it.
Well, maybe I'll just add, I mean, this is about modernizing the payment system, modernizing Medicare, and it really, that is not only from the efforts of our long work together since earlier this summer, but it's the stakeholders that are standing in front of you today, too, that weighed in to say this is the right approach, we're on the right track, and they can probably offer some comments about why this is the right track.
Let's get Congressman Welch into this.
The reality is, this is where the money is. It's what Senator Wyden said. And what we have is a situation where we've got these providers here, insurers, doctors, that want to move into the better way of delivering care, but they're hobbled with the old system of payment. And they've got bottom line responsibilities that they have to meet. So there's a transition that has to occur. And this legislation essentially is allowing us to make that transition. These folks want to do the job. You talk to doctors and they get it. They don't want the senior to be that ball in the pinball machine just bouncing from one procedure to another with nobody in charge. So this is putting that on the table. The other thing that's so great about this is it's not the debate we have around here about cutting benefits as the way to make healthcare sustainable. It's about improving the way we deliver care and having the right incentives so that we can have quality and access. Those two things are essential. But if we just have a dead-end debate about cutting our way to solvency instead of improving quality in the payment systems, we're not going to get there.
Let me see if I can drag some of our providers and leaders into this. The four of us was just visiting with the group. Dr. Ken Coburn is here from Pennsylvania, and I thought that they were on the way to better care at lower cost. Ken, you were saying something about saving over 20% as the care improved. Maybe you could just take people through this a little bit, and then we're going to get some of the rest of you into this.
Yeah, well, thank you. It's great to be here today. And my team has been working on this problem for about 12 years in a Medicare coordinated care demonstration project, which we're one of the last sites around the country that have been successful in this. And the big challenge is how to take what we've learned over that time and others here on the provider side and make sure that those critical processes, those critical standards, those critical system elements of data and key protocols and team-based care and a variety of things that we've learned do work versus the sea of things that have been tried that don't work, and make sure that that's embedded in these new models of care that are being proposed. And I'm incredibly excited about this because these sponsors in Congress and their staffs have been working long and hard and getting lots of feedback from lots of us up in the room to ask us really in-depth questions about if you had to build this and build it so that it really, really worked and wasn't just another buzzword for care coordination that comes in many varieties that don't work very well, how would you build it? And a lot of that feedback that we've all been able to contribute is embedded in this bill. So it's very exciting. I think this builds substantially over where we've been before about actually making this work.
Let's bring some of our other providers. Just please come on forward. We want to hear from all of you.
Hi, thank you. I'm Alan Muni representing Cigna. I'd like to address anybody who may doubt that this approach actually can work. Along with my colleague Herb Fritsch and I, we can speak for both the employer-based side as well as the Medicare-based populations. We have models in place that are already delivering through our partners and our providers really good improvements in quality and cost. What this bill does is further leverage into every nook and cranny, as was said, the transformation around chronic care that is started in this country and really needs to get leveraged in order to create the sustainability in the Medicare program that we all want. So it's a very good thing, and it's already the tenets are working. Thank you.
Andrew Dreyfus from Blue Cross Blue Shield of Massachusetts. For the last 5 years, we've sponsored the largest commercially based payment reform initiative in the country. And it's been studied extensively by independent researchers. And what it's shown is exactly what this legislation is titled. Quality is up, especially for patients with chronic illness, and costs are down. What we need to do is create a national framework for this kind of work, and this legislation does this. So we're enormously excited. We know it works in rural areas of our state, urban areas, for patients who are low income, for patients who are more advantaged, for patients with chronic illness and acute illness. This is the kind of model we need for the nation. Thank you.
You mentioned to the four of us that the way you saw it is taking some of the work that you pioneers have been part of and basically taking that to the gates of Medicare and being able, with the changes that we're talking about, to push through and make it.
Exactly. So a lot of the most far-reaching initiatives in the country have been working for the under 65 commercial population. But Medicare is the single biggest program in the nation. When Medicare changes, it changes physician practice in a broader way. And so we know it works. We want to see it adopted in Medicare. We want to see some of the rules that have actually shackled physicians and plans loosened so that people can continue to innovate as we've done for the under 65 population.
Please, anxious to hear from you.
So I'm Bill Bornstein, Chief Medical Officer at Emory Healthcare in Atlanta. And by the way, if the Senate's having trouble getting Coca-Cola, we can help with that. But we're a large academic medical center. We treat patients with many of these chronic illnesses, and we do a good job of treating those illnesses. But where we're frustrated is treating patients, and patients who have multiple illnesses, and bringing those parts together. And as you've heard from my colleagues, most of us believe that the future is these kind of coordinated models where we really are put in charge of how the money should be spent for caring for the entire patient rather than their individual problems. I'm an endocrinologist. I take care of patients with diabetes, and I can tell you that seeing a patient with diabetes every 3 or 4 months for 15 minutes or 20 minutes just doesn't work. What we need is the ability to have continuous relationships, to use the technologies that's out there, and so that I can have, and the other partners in my team can check in with these patients, and they can check in with us on a regular basis. The devil, though, is in the details. So while you've heard of success stories, some of the other experiments haven't worked, and we're very pleased at the leadership that these senators and congressmen have taken with this legislation, and as Ken pointed out, taken the input on these crucial details around risk adjustment, attribution, and other aspects that are going to be critical for success. One other important aspect that I want to emphasize relates to physicians and other care providers who are getting burned out in the current system, frustrated by these challenges, not being able to achieve the kind of care that we all went into healthcare to try to provide for our patients. And it's these kind of models, and in particular a model like this one, with the details done right, that will rejuvenate our providers, help us attract more primary care providers and retain them in primary care, and other providers in specialties that take care for chronic care. So we're very appreciative of this legislation and the leadership that the senators and congressmen have shown. Thank you.
Our tenacious press has some more questions, so let's hear from some others, and then we'll take them.
Sure. I'm Andrew Racine. I'm the Chief Medical Officer at the Montefiore Medical Center, which was a pioneer ACO, is a pioneer ACO, and it's in the Bronx, in New York. We take care of a population of folks who are not only generally underserved, but also low-resource folks. I think what you're looking at here today is what responsive government looks like. And by that I mean, and I'm going to echo many of the comments that Bill and Ken others have made here, what happened here was the folks who designed this legislation, Senator Wyden, Senator Isakson, and the others, took a look at what the pioneer ACO experience was like. and they found what worked on the basis of input that they got from those of us who were doing it. And to get back to the question of how does this differ from ACOs, it's an important question. And there are elements that came out of the ACO experiment that were incorporated into this legislation that improves on it. What are those elements specifically? Number one, in the ACO experiment, the way it currently works, there's nothing to say that you can't conduct an ACO with a fee-for-service payment arrangement, and many of them do. The fact of the matter is that those of us who are in places like the Bronx, we take care of about 500,000 people. 270,000 of those 500,000 are in some shared risk arrangement. It is really impossible to deliver the kind of care you want to deliver unless you move away from fee-for-service, unless you put the nexus of decision-making for a clinical decision in the same hands of the people who are at risk for the finances. That's what you want to do. That's what the bill does. That's extremely important. Number two, we also know, on the basis of what we've done in the ACO in the Bronx and other places, that if you really want to make inroads into saving costs, you have to concentrate on folks who are going to cost money, and those are folks with chronic illness. So this specifically incentivizes people to go to look for the patients in their population who have multiple chronic conditions and to see what can be done for them. That's the second thing. The ACO doesn't do that. This does that. The third thing, which is really important, is that it incentivizes team-based approach to care. You've already heard this from some of my colleagues. You cannot take care of people with chronic illness in a single sort of the Marcus Welby, if you will, approach, where you have a really caring physician who's got a one-on-one relationship with their patients. There simply aren't the resources, and the reason for that is that chronic illness begins with the social determinants of health. And if you're going to address those social determinants of health, that's not something that happens in the exam room. You need a team of people that are going to do that. This legislation also speaks to that issue. And so I think all of those things together, plus other elements of it, incentivizing the patients themselves. There are elements in this bill that incentivize patients to also save costs, and the ACO doesn't quite do that. So this builds on the experience of those of us who did the ACO and who are doing the ACO and actually gaining real savings. I mean, Montefiore saved $23 million for the federal government working in its ACO in the first year. It builds on what we found out doing that experiment and just moves the experiment forward. That's what legislation is. It's an iterative process. And I think this is a real improvement. And then the only other thing I would say is, since I'm a general pediatrician, I don't normally deal with folks in the Medicare program. I would be remiss if I didn't point out to the audience that this is a precept that originated in pediatrics in 1967. Patient-centered medical homes come from pediatrics. And I know that Senator Isakson is a big supporter of children's hospitals, but this came out of pediatrics. It was a design for patient-centered medical home for children with chronic illness. And I'm just very happy to see that the folks in the country are finally catching up with what the pediatric community has known for 40 years.
Let's all agree pediatricians rock too. Folks had a few more questions.
Yeah. Question for the lawmakers. Senator Wyden mentioned that you sort of put the baseline for this in the SGR replacement bill in the Senate, and I'm wondering what your hopes are, if you want to continue to push for that in the SGR replacement bill, or if you see another avenue for the legislation. Both House and Senate would be great.
Well, first of all, everything we do in the steps we take in the House and I think in the Senate needs to move forward to a permanent solution on the doc fix. And I think some of the steps that were taken on a bipartisan basis, both Senate Finance and in House Ways and Means and Energy and Commerce, have a lot of the same tenets that we're offering here, actually. And again, it's about rewarding. It's not about rewarding activity. It's about rewarding results. And that's the model for the future. And that's the direction we're going.
Could you address a little bit more about how you'll hit your target savings? I think it's $25 billion a year. CBO typically doesn't give care coordination a big score, so how do you do that?
Well, first of all, I think there is no substitute for actually producing approaches, whether it's Dr. Coburn, whether it's the folks in Alabama. Those are going to be the people that are going to get interviewed by CBO and other people, who actually count. What we have tried to do at every stage of this is to kind of lowball the potential savings, which we view as very dramatic. For example, we have created a hypothetical senior. And Congressman Welch said it very well, who just sort of ping-pongs back and forth through the system. And essentially, after they get their free physical from Medicare, everything just kind of goes haywire until they end up in the hospital emergency room with a $1,000 plus deductible and can't even remember all the various providers they saw in the process. So if you take that hypothetical person, we call her Mrs. Jones for purposes of our discussion, and you were to save even perhaps 5% a year, okay? 5%, Dr. Coburn and these practices saving upwards of 20, you save 5%, you would have, in effect, savings of $250 billion over 10 years just as you get better care. So we are not underestimating the near root canal-like exercise of going through scoring and the Congressional Budget Office and the like, but I think there's no substitute for having these kinds of specific plans that aren't talking about it in the abstract. You just heard from several practitioners for whom this is not a debating kind of theory. They're doing it in the real world.
And you have time for 2 more questions.
All right. Lori.
Representative Paulsen.
Great.
So you're in Ways and Means, which is very focused on tax reform right now, and SGR to a certain extent. Is there either substantive or political bandwidth in the House to start addressing these kinds of problems with Medicare, given the political history of this issue and how everybody sort of shied away from the program for now?
Well, that's why we've been working on this as a small group over the last, well, since early summer. You know, the truth is any solution in either Medicare, helping protect the solvency and making forward progress in lowering healthcare costs and improving quality, as well as tax reform, is going to have to be done on a bipartisan basis. And it's been great working with Senator Wyden. He's going to be leading the Finance Committee now, but we've worked and had great conversations with both the members of the Senate Finance Committee on tax reform, joint hearings, et cetera, and the same thing is happening now in the SGR fix. And so all the first forward momentum tenets are there, and I think we're just going to continue to push and advocate and move this forward with our leadership.
You bring one of our other.
David Certain with AARP. I mean, one of the things that we're really excited about is really the change, hopefully, in the tone and the tenor of the debate. As I think Representative Paulsen mentioned, we've been involved in this false choice debate the last few years about more spending or cutting benefits, and that's certainly not a choice that works for most seniors around this country who are really already struggling to pay for their health care. They already pay one of every $6 for health care, and we don't have a whole lot of seniors that come up to us and say, we don't pay enough for our health care. And instead, we think that this kind of approach is looking to really change the tenor of the debate to how do we actually reduce the cost of health care and at the same time provide better quality and better value. And if we change the whole tone of the debate, we think there's actually more opportunity to make progress in Medicare and actually deliver better quality care, better value, have more patient involvement, and save costs at the same time. And that's, I think, something that everybody in Congress can get behind. So we're very encouraged if we change the tone of this debate, even if we can't necessarily pass a bill this year, we certainly want to try to push this kind of a debate.
Lori, the only other thing I'd add is I think by the time we're done with the challenge of fixing the reimbursement system, you know, for doctors, we will have started chronic disease reform. I think I mentioned to you that we were able to get a couple of major changes in the finance bill, very consistent with what the House is talking about. There are these plans called CSNPs, chronic special needs, you know, plans. And with the changes that came out of finance, we'll ensure that seniors will have individual care plans, which is something you'll hear about frequently from these kinds of providers. And also, we would expand telemedicine to make it easier, particularly for urban and rural areas, to be able to communicate with each other. So, as we've talked about, nobody is suggesting that this entire bipartisan approach is going to be passed in the next 15 minutes. But I do believe, not only do we agree that this is the future, this is where Medicare reform has to go, I think we're going to get the foundation, the beginning foundation, I think we're going to get that into the SGR bill. We thank everybody for coming, and what a great lunch.